Hi, everyone, and welcome to Chapter 6. Today, what we're going to do is we're going to start talking about our body systems. So in Chapter 1, we talked about sort of the introduction to anatomy. Chapter 2 was on chemistry. Chapter 3 was talking about cells. And then finally, we talked about a little bit more in detail about cells and cellular function in Chapter 4. Chapter 5 was tissues. And now we finally get to start moving a little bit further on that level of organization. And now we're going to start talking about organs and organ systems. So the first organ system that we're going to talk about is called the integumentary system. So the first thing that we have to think about is talking about skin and its tissue. So when we think about the idea of an organ is going to be made up of two or more types of tissues. The skin itself is actually the largest organ in the body when we think about it by weight. And when we talk about the skin, sometimes you're also going to hear the term dermo, dermato, or cutaneo. So when we talk about the cutaneous membrane, that's what we're thinking about in terms of skin. And so when we think about having skin, along with some other accessory structures like hair, skin, and nails, we start thinking about the integumentary system. So when we think about what organs are involved, again, you have your skin, your hair, your nails. We're going to start talking about glands as well, and some sensory receptors as well around the skin and around the nail beds. When we think about skin itself, we're going to be thinking about the fact that there's actually kind of two layers to the skin. The first layer, the superficial layer, is going to be of epithelial tissue. And so in Chapter 5, we spent time talking about that stratified squamous epithelial tissue. And then we have this underlying connective tissue. And the connective tissue is going to be a mixture, actually. It'll be a little bit of areolar connective tissue along with some dense irregular connective tissue. So when we talk about the outermost layer, we refer to it as the epidermis. And again, if you hear the term derm or dermato, we're thinking about skin. And epi is going to be above. So this is going to be the first superficial layer, the epidermis. And that's where we're going to find that epithelial tissue. Finally, deeper, we're going to hit that dermis. And that's where we think about that connective tissue residing. All right, so this is just a picture to sort of show you this idea between the dermis and the epidermis. On the top layer, you're going to find the epidermis, and this is going to be that outer layer. And it's going to be comprised of stratified squamous epithelium or stratified squamous epithelial tissue. And when we think about stratified, it means more than one layer. So we can actually see in this dark purplish color that there is a great deal of layers of cells kind of all comprised here. And remember that the cells themselves are very flat, so they kind of sit on top of each other. Now, when we talked about this from a tissue perspective, we mentioned the fact that epithelial tissue doesn't have blood vessels. And so what happens is it gets its nutrients from these underlying tissues, and eventually, the higher you go, the more superficial these cells become. They actually have lost nutrients, and most of them are dead, and they're going to slough off. So it takes usually about 28 days to make this go through, that we can eventually see. So again, we start to notice that we have this sort of underlying tissue, and we have this, sort of basement membrane anchoring everything together. When we think about the dermis now, we're thinking about this layer here. And actually, let me do it in a different color. So we have the dermis here in blue. And again, we have the epidermis on the top. The dermis is going to be becoming more deeper tissue. And this is going to be actually two layers of skin that we're going to find. Most of it's going to be comprised of connective tissue, and we're going to see that this connective tissue has a mixture of collagen and elastic fibers. And so when we talk about this tissue, again, there's two different types that we'll actually see. More towards the basement membrane, we're going to find areolar connective tissue. And the deeper we go, we're going to find this dense, irregular connective tissue that has sort of this mixture between collagen and elastic fibers to allow for the skin to move in different directions, but also keep some strength there. And then finally, what happens is we actually truly have a third layer, but we don't incorporate this when we talk about skin. This is called the hypodermis layer, or sometimes you're going to hear subcutaneous layer. And sub means below. And again, if you see that cutaneo, it means skin. So dermo, dermato, or cutaneo could potentially mean skin. But most of the time we'll refer to this as the hypodermis. And this is going to be composed of adipose tissue. There's a little bit of areolar connective tissue in there as well, but mostly it's going to be adipose tissue. Again, it's not really considered part of the skin, but it's sort of the insulating layer. So for a moment, just look sort of at your forearm and start picking up some of your skin. You can actually feel that epidermis, and you can feel that sort of superficial composure there. Then again, a little bit deeper, we'll have the dermis. And then finally, even deeper to that, we're going to find this adipose tissue, that hypodermis. And what it's doing is it's basically making a separation between the skin to the muscle. And so when we start to look at these layers, we'll have epidermis, dermis, this layer of adipose tissue, and then finally below that we'll find our muscle. Usually where we find adipose tissue is again around coverings around various vital organs or vital areas. So you'll see that there's actually a great ton of blood supply around this subcutaneous layer. And again, it's because it's a great insulator. So it helps to trap in heat. It helps to be sort of a protective layer. And again, we do find that there is lots of blood vessels in this area that are going to supply the skin. All right, so here's a really good picture to be able to sort of see and identify a lot of things on here. When we think about this top layer of skin, again, think about that being that stratified squamous epithelial tissue. And then what you're going to see is, again, the superficial layer is going to be your epidermis. Then finally, when you find that basement membrane that we look for, that's going to divide the epidermis from the dermis. Now, there is a lot going on in the actual dermis layer. So we're going to find blood vessels, we're going to find different types of glands, we're going to find our hair follicle, we'll find some muscles, and we're even going to find some receptors in here as well for sensory. So in the epidermis, again, there's not a lot of cells that we're going to find. There's not a lot of structures we'll find. But again, we have those layers of very protective cells with that stratified squamous. In the dermis now, again, you have a series of things going on. So we're going to find blood vessels because remember, epithelial tissue is avascular, but connective tissue can have blood vessels. So we find some arteries and veins. You can also see here that, again, we have some sensory receptors, these different corpuscles. And we'll talk more about those here in just a moment, but basically they help us to have touch and have sensation. You can also see here that we have the hair. And so the hair is actually going to be coming down into this layer. And we can find the hair follicle itself where the hair actually sits itself in. Next to the hair follicle, we actually find a muscle called the erector pili muscle. And this is what helps to make the hair on your arms stand up when we think about being cold and why we have this sort of almost fur-like component to us. When we get cold, our hair stands up. Again, you're going to find some glands. So next to the hair follicle, we find what are called sebaceous glands, and I'm trying to highlight it in this more turquoisey color. Let me see if I can do it. I'm going to do it in black. So you can see that sebaceous gland. But we also have different glands too, like our sweat glands as well that we can find. And we'll talk about the different types of sweat glands here in just a moment. So there's a lot going on in the dermis, and I hope you kind of understand why, again, you're going to find more in the dermis than the epidermis. Epidermis is more of that protective layer, but the dermis, again, has where a lot of the function of skin is going to come from. And then finally below, again, we don't consider this part of the skin, but we make mention of it, is this hypodermis layer, or sometimes referred to as the subcutaneous level. And this is going to be composed primarily of adipose tissue, but we will find some larger blood vessels actually sitting in here for, again, that insulation and that protection. All right, let's get a little bit more in detail about the epidermis here. So really quickly, I'm going to show you this picture and I'm going to go back to a slide. Again, thinking about the epidermis, as I said before, it is going to be of stratified squamous epithelial tissue. But we actually consider different layers of the epidermis. So the way that I remember this is from the most superficial to deep. And the way to remember it is come, let's get sunburned. It's kind of a cute way to remember it. Come, let's get sunburned. You have the stratified corneum, the stratum lucidum, the stratum granulosum, spinosum, and then finally the stratum basale. And so when we talk about these layers, again, we're thinking about the most superficial and going deeper in. So we'll talk a little bit more about that here in just a moment. But when we think about the epidermis, again, it's stratified squamous epithelial tissue, and it rests on that basement membrane. So keep in mind, there are no blood vessels. It's receiving nutrients and nourishment from those underlying connective tissues. But the deepest layer is called that stratum basale. And again, it's nourished by the actual dermis. And as the cells grow, they are going to basically push upward. They're going to become more superficial. They migrate toward that free surface. And as they migrate, they get older and they actually begin to die. So when you think about that most superficial layer, it's going to have keratinized dead cells. And when we talk about the idea of keratinization, it's actually the process of actually hardening these cells. And again, they start to basically dry out, they flatten, and they die. So when we think about this keratinized dead cells, that's what we're going to see in that superficial layer. And again, it's great for protection. It's great for protecting ourselves against abrasion, and it needs to be quite tough. Another big thing too that's very important is the idea that we have this keratin accumulation. And keratin, when we look at the term kerato, it actually means horny tissue. So if you look at a rhino's horn, it's composed of keratin. So it's this very tough and fibrous protein. And again, if you think about a rhino's horn, it's very, very strong. And it's also waterproof too, which is another thing that's very important to keep in mind. So as the cells actually hit that more superficial layer, they become really tightly packed and they form this outer layer. That's the stratum corneum. So again, when we think about those layers, come, let's get sunburned. You have the corneum, the lucidum, you have the granulosum, come, let's get sunburned. We have the spinosum, and then finally we have that basale layer. I still have to use the mnemonic device every once in a great while. But the stratum corneum, again, eventually they shed off and you're going to get rid of them and we'll be able to generate new cells and be able to have that new superficial layer. Now, one thing to keep in mind too, that we're going to talk about is that we have thicker areas as well. And actually the stratum lucidum is not always found everywhere. It's only usually found on the palms and soles of your feet. So the thickest areas that we have, and again, the more tougher areas are your palms and your soles. But most of the body has this more thinner epidermis that we're going to see. So going back to those layers, come, let's get sunburn. The outermost layer is going to be of dead keratinized cells. And when you start to look at them, they look very flat. And again, that's kind of what we see that when we look at these layers, they do look more like they have a shape to them, sort of in that deeper layer. And the further outward you go, the more they look like they're stratified squamous cells. You kind of see that squamous, that flat look to them. Now the lucidum, when we actually look at the stratum lucidum, it sort of has a clear layer to it that we see. And if you think of the term lucid, you think of clear. This is only found in those thick-skinned areas, so the palms and soles. So if I was to ask you, where would you not find the stratum lucidum? You're not going to find it in your forearm. You're not going to find it in your forehead. You won't find it on your buttocks, but you will find it in the palms and soles of your feet. And then we get to the stratum granulosum. The reason that they get their names is actually because they have little granules to them. And this is actually where we start to notice that the cells begin to die in the granulosum. So they start to kind of flatten off and kind of look a little bit funny. And the stratum spinosum, they have more of a spiky appearance to them, hence why they get their name spinosum. And then finally in the stratum basale, that very deepest layer, it's actually only one layer of cells, and that's considered the mitotic layer. This is the one that the cells are going through that cell cycle in order to replicate. So when we think about the cells going from a parent cell to two identical daughter cells, this is occurring at that stratum basale. And so again, another big thing to keep in mind is that with these different structures come different functions. So when we think about why we have this epidermis, again, think about these dead keratinized cells. They protect against water loss because of that keratin. Again, they're very good against, if you have cuts or scrapes or harmful chemicals, they really are going to be very suitable in this sort of world. And also they're going to protect us against any pathogens. Although we have microbes that like to reside on our skin, as long as we have intact skin, they stay on the outside and they don't go inside. And in case you need a little additional help trying to remember these layers, here's a good little table to look at and to overview. Now, some of the cells I want to talk about within the epidermis that we'll find are melanocytes. So if you see the term cyte, C-Y-T-E, that means cell. And melano actually means black. So if you were to hear of like melanoma, we talk about it being a black tumor. Melanocytes are actually located within the stratum basale. So again, that most deepest layer, and they produce this pigment called melanin. For most of us, we know what melanin is. This is what helps to create our skin color. But that's not the only function that melanin has. It actually helps us to absorb UV light. So it ends up being very protective, as well as, again, it helps us to provide our skin color. And what happens is that melanin is actually going to be given off to these keratinocytes, the cells that help to make keratin. And again, they protect our cells from the effects of UV, as well as, again, they help us to provide our skin color. Now, some really cool things when we actually talk about skin, when we think about the number of melanocytes a person has, every person is born with the same number of melanocytes. What changes, and this is where heredity and genetic factors play in, is the amount of melanin produced. So that is under genetic control. So we kind of mentioned this before. You have certain genes in your body, but they're not always expressed. Now, although we're born with the same amount of melanocytes, it can vary the amount of melanin. And you can even probably see that in your own families, why some people have darker skin than others. It has a genetic role to it, as well as a little bit of environmental. So there's varying distribution in the size of melanin, as well as, again, the amount of melanin produced. And just to keep in mind too, again, the more darker skin you have, the more melanin production you're going to see, versus someone like an albino that has very little to no melanin genes or has a mutation within it. They actually lack melanin and they don't have any dark skin tone. And usually, again, they have blindness, and you'll see changes within their hair color as well, along with some other issues that will kind of coincide with it. Now, there is a little bit of an environmental factor as well, like I mentioned before. If you were to be out in the sun for long periods of time, you're going to have darker skin. If you were in a tanning bed, you're going to have darker skin. And even X-rays can also affect skin color as well. Now, from physiological factors, so some things that happen within the body, this can actually also affect our skin color. So depending on your true oxygen levels and how the oxygenation is within your blood, sometimes a person may have a pinkish association with them. So if they have proper oxygenation, they should have more of a pinkish hue. Maybe someone that is anemic may actually look more pale. We tend to use the term paler. And that's to kind of express the fact that they don't have that pinkish hue, versus someone that's gone through carbon monoxide poisoning may actually be cyanotic, or someone that has respiratory issues, like someone with COPD, you may actually see a bluish hue to that person. And we call them cyanotic or undergoing cyanosis. Cyano means blue. So that's just kind of the way to remember it. So if you see more of a bluish hue, it's cyanotic, versus, again, we kind of hope that everyone has a little bit more of a pink hue to their skin. But you can also hear the term paler, where someone may actually be very peaked, and that's because of issues with oxygenation. Very common in someone that's anemic. With vasodilation and constriction, again, that can change your blood cells and potentially change the color of your skin. And if you think about this too, we actually notice it in heat. So if you've ever been outside on the really hot July 4th day, because of the change to blood flow, you'll have vasodilation and constriction. So you're actually dilating your blood vessels to try to give off some of that heat. And you may notice that your skin becomes a little bit more red, or you may see some reddish tones within your face. Again, that's due to these physiological changes in skin. Versus when it's colder, you're vasoconstricting, you're trying to keep that heat in and not get rid of it to the outside world. So again, those little variances can also affect your skin color. Now, another big thing too is the accumulation of keratin from our diet. So that may give us a little bit more of an orangish hue. And jaundice is actually due to accumulation of something called bilirubin within our cells. Usually this is a problem with the liver. And this is very common in infants because they have problems with their bilirubin production and just having an overproduction of bilirubin, as well as we may see someone that has liver problems also having jaundice as well. And this is usually going to have a yellowish hue to their skin, or you may see a yellowish hue to their eyes. So that's a very common thing to see. And that's something to keep in mind too, especially in a healthcare situation. You may have someone with extremely dark skin. And so it may be hard to pick up on these issues with pallor and cyanosis and jaundice, but you look at other areas, you look at palms and soles of feet, and you look at mucosal membranes, and you also look into the eyes. And those little factors will be able to help you along the way. All right, so again, just something to keep in mind when we think about sort of this from a clinical perspective, the idea with indoor tanning and skincare. Again, the more exposure to light is actually a good thing. Sunlight is very useful to us because it helps us with vitamin D. It also does help us with our melanin production. However, it's always thinking about extremes. So high exposure to sunlight or using tanning beds in a very high volume causes melanocytes to produce more melanin. And so your skin's going to darken, which makes sense. But when you overdo it, it can cause issues with UV radiation. And because of that, it can cause some problems and mutations to our genetic material. It can actually damage our DNA. And because of that, it can actually overwhelm our natural protective responses against skincare, as well as actually create these skin cancer cells as well. So some of them to keep in mind, and we'll talk a little bit more about this here in just a minute. You're going to hear about basal cell carcinoma as well as squamous cell carcinomas. They tend to arise from our epithelial cells in our skin. And so again, very common that you'll see with someone that has overexposure to UV radiation and sunlight. Melanomas tend to arise from melanocytes. And so when we think about melanomas, we tend to see more blackish tumors. And so they're the least common. It's only about 4% of skin cancers. However, when we think about mortality rates, melanoma is metastatic cancer, which means it metastasizes and it moves to different areas. And it causes about 80% of skin cancer cell deaths. And I like to talk about this because actually my own grandfather passed away from melanoma. He was 36 years old. And so in our family, this is something that we take very seriously because of those issues. And again, although it's not very common, it can cause a great fatality. And again, you can lose a loved one just due to this issue with cancer and this metastatic, cancer taking place. But keep in mind that, again, you will see basal cell carcinomas as well as squamous cell carcinomas as well. And they tend to arise from those epithelial skin cells. We'll talk more about that here in just a moment. But again, just kind of bringing this to why this matters and why you're learning about these cells. All right, so in the dermis, that is now our second layer of skin. This is going to be the most this is going to be the deepest level versus the most superficial would be the epidermis. And what we're going to notice is that we have actually different types of connective tissue in here, as well as we'll also find some muscle fibers too. Now, what happens here is that we have something called the derma papillae, and you can somewhat see it here. Let me see if I can get you a little bit more of a picture. This is the dermal papilla right here, between the ridges. And it helps us to bind to these underlying tissues. But I want you to keep in mind with these dermal papilla, this is actually what allows us to have our fingerprints. And so if someone were to just burn off that, that epithelial tissue, that epidermis layer, you still would be able to have a fingerprint. So you would have to be cut very, very far to get into that fingerprint layer due to these epidermal ridges called the dermal papillae. Like I said, the dermis tends to contain mostly connective tissue. Most of it that we'll find is dense irregular connective tissue, as well as a little bit of areolar connective tissue, just kind of binding everything together. Like I said, inside the dermis, we see a lot. We find different glands, like our sebaceous glands for our hair oil. We find sweat glands. We find our sensory receptors, as well as we find the hair follicle itself and blood vessels. There is a lot going on within this layer. So definitely something that you want to know and kind of understand what will be found in each layer. Now, like I said before, when we talk about these layers, when it comes to the dermis, we have something called the papillary layer, which is where we find that dermal papillae. And that's going to be the thinner of the two layers. It's only about 20% versus 80% is going to be what's called the reticular layer. And as I said before, with the papillary layer, what we're going to find is that is going to be the most superficial layer, and we find areolar connective tissue that's kind of anchoring everything together. Versus the reticular layer is going to find dense irregular connective tissue. And with dense irregular connective tissue, it's kind of a combination between finding collagen fibers and elastic fibers. And they're not made up in this sort of wave-like pattern. They're kind of like all over the place. And that's a good thing. It's what allows our skin to move and kind of go in these different directions. And it's the way thicker of the two layers. All right, now that we've talked about skin, we need to talk some about some of those accessory layers and accessory structures as well. So thinking about this epidermis and again, extending it to the dermis and hypodermis, some of the structures that we're going to see are like the hair follicle. We'll also talk about nails and we're going to talk about some of those glands. And so first that we're going to talk about are actually nails. When we think about your nails, they're not just to look pretty and to put nail polish on and to grow very long. They're actually protective coverings on the ends of our fingers. And so there is a purpose to them. They are protective. They're a protective covering. And so when we think about the parts of the nail that we're going to see, there's 3 different parts I'm going to ask you to know, or at least somewhat have an understanding of. The nail plate is the majority part that you're going to see. It's actually going to overlie over something called the nail bed, which we can see right here. This is the nail bed, and you can sort of see how that plate just sort of covers it up. Then what you're going to see on the actual nail is that there's a free edge, and then there's going to be an edge that's actually connected kind of to the digit and to the skin, and that's at the cuticle. And this is what you can push back. Now, what you'll notice is there's like this crescent-shaped moon-like structure called the laluna, and that is actually the growing region of your nail. So when you think about your nails, it kind of works just the same way as skin. They're going to be growing from this mitotic region called the laluna, and they start working their way up. And so it's kind of, again, like more of a half moon shape that you're going to see. And again, that's sort of how the growth is able to take place. And like I said, these sit over top of the nail bed. That's actually the surface of skin that's actually under the plate. And that's basically what you're protecting, is the nail bed itself. And like I said, I really like this picture because it kind of gives you an idea of thinking from superficial to deep. So you can see that skin layer, you can see that epithelial tissue, and then kind of dermis going on. And then we can see that we have this adipose tissue and fat kind of covering everything up. And then again, it allows you to see where that nail plate is actually residing, and that nail bed right here. And then again, you can see a little bit more adipose tissue sort of surrounding the true bone. And when we look at the bone here, you can actually see how there's actually what's called a joint in between these two bones. And we'll be talking about that here very soon. All right, next we're going to talk about the hair. And we're really thinking about the hair follicle. So when you think about hair, it's on all surfaces of your skin except for in a couple areas. So you don't have hair on the palms or soles of your feet. You also don't have it on your lips or nipples. You can have it around the areola of the breast, but you will not actually find it on the nipple. And on some parts of the reproductive organs, you're not going to find hair, but pretty much everywhere else, you're going to find hair. We are mammals. With a hair follicle, this is going to be what we actually find going into the dermis itself. It actually extends into the dermis and sometimes even into the subcutaneous layer that we look here. So when we're looking at this component of the hair, this is what we're thinking about as the hair follicle. And what will happen is when we talk about hair, anything that is above the dermis is considered to be the shaft of the hair. So that's the dead epidermal cells that we think about that again are kind of sloughing off or, just growing longer in those strands that we're losing. Again, we actually look for the follicle coming down. And what we're going to see is that we find this bulb as well as the root itself. So this part is considered the root. This is the bulb area. And then again, this is the shaft. And the bulb is going to be where the hair is actually dividing. And if you notice here, there's an association with blood vessels because again, you have to get that nourishment and those nutrients to allow the hair to grow. And again, right in here, this is where we would end up finding the actual true bulb. And again, that's where this division of cells is going to take place. And as it grows longer, it's going to work its way outward. And remember, anything that is above this epidermis is going to be keratinized cells. They're going to be dead epidermal cells. So the papilla itself in the hair actually contains blood vessels, again, to nourish it. That's a big thing to keep in mind. And what you're going to notice too that's kind of interesting when we go to look at this guy, you're going to see this sebaceous gland right here. And sebaceous glands produce sebum. Sebum is oil. So this is what allows the hair to have nourishment and have that oil protective covering. But we're also going to see as well that there's a muscle, the erector pili muscle. And its name kind of says it perfectly. This is what makes the hair on your arm stand up. So when you're cold or when you're frightened, you have those goosebumps, and it allows for, again, that contraction to take place and to basically let the hair stick straight up. So just something interesting to keep in mind. Now, one thing to keep in mind too, just from a clinical aspect, again, kind of bringing it all together, I said that basically every person has hair, and that's correct, that mammals have hair and we have it pretty much in everywhere on our bodies. But unfortunately, we are going to see some issues with hair loss. And so the most common type of baldness is what's called pattern baldness. And it's very much more prominent in men than in females. So sometimes you'll hear about male pattern baldness. And usually what happens is with lower levels of testosterone or even estrogen. So when men have very low testosterone levels, you tend to see this male pattern baldness. We also call it androgenic alopecia. And for women, it's actually issues with lower levels of estrogen. But we talked about cells before, and we talked about this idea of cell division taking place. So we have these progenitor cells that are actually lacking in bald spots. Although there are stem cells present, we don't have those terminating, last, sort of specialized cells called those progenitor cells. And so again, that's where we would notice these bald spots. And unfortunately, there's actually an autoimmune disorder when we talk about alopecia called alopecia areata, which actually the body produces antibodies that truly attack the hair follicles. So they do not have hair either. And they don't have hair anywhere. They don't have hair on their eyebrows. They don't have hair on their skin. You're not going to find it. They just don't have hair. And unfortunately, again, when we think about structure, hair is very important for protection, and it allows to pick up debris and to make sure that things are not getting inside our mouth and our eyes. And it can be very detrimental as well. So it's not just no big deal. It can actually be quite devastating for those that have this hair loss. All right, so now that we've talked about this idea of the hair follicle, we want to talk about glands. So we're going to talk about sweat glands, and we're going to talk about sebaceous glands. Sebaceous glands are what we know as producing sebum, and that is what we consider oil. So sebaceous glands are your oil glands. And again, they're very closely associated with the hair follicle because they help us to produce sebum. And what sebum is just basically this fatty material and cellular debris, but it makes this oil. And it helps to keep our hair very soft, as well as it helps with protection of water loss. So it makes it waterproof. Now, the issue that we know of is, again, excess sebum, especially during puberty, is quite common. So you'll see that women tend to have, or even men tend to have a little bit more greasier hair. But not only do we notice it with our hair, like on our top of our heads, we also have issues within our face and on our backs and things like that. So when we think about this excessive sebum, sometimes it can actually track bacteria, and then that can result in acne. So when we have these overproductive sebaceous glands with them trapping these kind of little buggers and these nice little pieces of debris and bacteria, it can lead to this inflammation and it can lead to infection. And that's what truly acne is. So just something to keep in mind. And they are absent on palms and soles, so that you do not see them on the palms of your hands or the soles of your feet. Otherwise, everywhere else, you will find sebaceous glands. All right. So thinking about the idea with acne, acne vulgaris is truly the issue that we see with this overproductive sebaceous glands. Again, very common in puberty. And if you think about it, we probably all went through that phase at some point where we had this very overproduction of sebaceous glands, especially within our hair or within our face. And unfortunately, those sebaceous glands get really clogged. They have extra sebum, they have extra cells. And like I said, because this also makes a really great environment for bacteria, which are called anaerobic bacteria, we see infection that's going to take place. So it affects about 80% of the people between 11 and 30. And most of the time we think about it being either treated with like a systemic antibiotic, for instance, like tetracycline. But you can also see, like, for instance, those that maybe have been on some acne regimens. A lot of times you'll see products with benzoyl peroxide or salicylic acid, and those are very useful as well as vitamin A derivatives. Those have been tested in the recent years, and again, are very useful in treating acne. All right, now thinking about sweat glands. So we talked about sebaceous glands that help with that production of sebum. Now we have sweat glands, and sweat glands are also called sudoriferous glands. I don't usually refer to them as sudoriferous glands, but they are. You will find them all over the skin, and we have different types of sweat glands. You can hear about eccrine sweat glands, or it used to be more known as merocrine glands, but usually I tend to use the term eccrine gland. And then we also have apocrine glands. Now, thinking about this, you are going to have, again, sweat glands found all over. Some sweat glands are actually used to regulate your temperature. Others are going to be more productive in puberty, as well as in response to emotions. So when we think about our eccrine or merocrine glands, this is going to be pretty widespread. They're found all over. So they're on your forehead, they're on your back, they're on your arms, on your legs, and they respond to temperature changes. Because again, as we become hotter, our body wants to regulate with that homeostatic balance, and therefore our blood vessels are going to actually dilate and help us to get rid of some of that heat, and through evaporation, be able to cool down. Versus apocrine glands are only found in particular areas. So this is in your armpit, the axillary region, as well as in your groin areas. And they more respond to pain and emotions. And again, these are more productive during puberty. And one thing to keep in mind too is that when we think about these glands producing this sweat actually is odorless. And especially if you think about like sweating during temperature regulation, like on your forehead or on your back, you don't tend to notice a smell associated with them. But with apocrine glands, you're going to notice that there probably is a smell associated with it. And it's because in your axillary areas or in your groin areas, this is a great place for microbes to reside. And the smell is actually from the microbes giving off their byproducts. And that's why you'll tend to see this pungent odor. And when we think of BO, it's not actually from your glands itself. It's not from the sweating. It's from the bacteria actually producing that smell. So just something to keep in mind. Now we have other sweat glands as well that are modified. We have ones that help with production of earwax as well as production of milk. And so again, just another little table that's sort of bring into this idea of all these different glands. All right, so now that we've talked about structure, again, now we got to think about this homeostatic balance and function. Your skin is one of the largest organs, and it's very versatile, and it's a vital spot for homeostatic balance. So thinking in terms of function, again, we talked about this idea that we have stratified squamous epithelial cells in that epidermis, and that's a great protective covering. Helps us again create a barrier. So we have an external and internal world, helps us to not let pathogens in. And it also helps with prevention of water loss. We talked about keratin being very useful in waterproof to help kind of retard some of that water loss. What we also didn't get a chance to really touch on too much detail is that there are sensory receptors in there as well that we found in the dermis. They are useful to help with touch. They're helpful to use to think about when we have like a deeper pressure or if we feel something very light, and it allows us to have some sensory response. Now, your skin is also a great area to actually excrete waste. Again, when we think about our sweat, we lose a lot of that stuff that we don't need. If you're thinking about regulating your water, regulation or regulating water volume, it's a great way to release some of that water is through our sweat. But not only are we releasing water, we also are going to release some electrolytes and again, some waste products that we just don't need. Now, another big thing about skin is it helps us with production of vitamin D. Vitamin D is very essential. Not only is it essential to our skin, it's very essential to our immune system, to our nervous system, and even to our digestive system, which we'll talk more about very soon. And again, the big thing is it helps with regulating body temperature. So just some things to keep in mind of structure relating to function. Now, we've already talked about this idea of regulation of body temperature before when maintaining that homeostatic balance, but it's important to keep this idea in mind. Again, we do not want to see very high levels of rising of temperature or lowering of temperature. We want to make sure it stays relatively pretty constant. And the set point is actually monitored by the hypothalamus to keep this going. The hypothalamus is a portion of your brain that is going to, again, regulate body temperature. And again, we really want to make sure that we stay as close as we can to that 98.6. So skin is going to play a major role with allowing this regulation of body temperature. And so when we think about heat, again, if your body was too hot, you would go through something called vasodilation to try to release some of that heat. And this is actually going to happen when we think about like our superficial veins. They're pretty useful for helping with that, and superficial arteries. They're very useful for helping for that vasodilation to allow for some of that heat to remove and to be to leave the body. When you're very cold, your body undergoes vasoconstriction of blood vessels to try to retain some of that heat. But heat is a big product of our metabolism. So when we eat, we generate ATP, we generate energy, and a lot of what we actually consume goes to maintaining our body heat, actually. But we also have some major active body cells too. Our skeletal muscles produce heat, cardiac muscles produce heat, our liver cells produce heat. And so when the body is too warm, again, we really have to have this monitoring of vasodilation and vasoconstriction. With vasodilation, it allows you to let heat escape. When your body is too cold, it's going to allow for vasoconstriction to take place. And so that's just something to keep in mind. Those more superficial guys are going to vasodilate and allowing that heat to be able to go. And when it's super cold, we'll have more of that vasoconstriction taking place. Now, there's some methods of how we're going to lose that heat. One way is through radiation. So thinking about like infrared. Conduction helps us to move that heat from our skin to cooler objects. So again, if you were to hold on to an ice cube, that's via conduction that heat would then start actually entering into the ice cube and eventually it would melt. With convection, this is helping to have heat loss into like actual circulating air currents. And then finally, again, when we think about sweat, this is thinking about carrying the heat away via evaporation. So when you sweat and you actually lose that heat, and sometimes you even feel cold after this happens, it's via evaporation. All right, so again, just some things to keep in mind, this idea of what happens when body temperatures rise and fall. So again, thinking all about that negative feedback and that homeostatic balance. Now, unfortunately, there can be issues either way you go, with too high or too low the temperatures. If you hear of hypothermia, this is going to be that your body temperature is way too high. And most of the time, this is going to be due to really hot temperatures. So again, if you lived in Arizona where you can hit 110, 112 degree days, or if that day is really humid, you can't really use that sweat to evaporate. That can be a problem. Again, if air temperature is too high, or if you had issues where your body actually gained heat from the hotter air, those can be some issues that you see. Some signs and symptoms of hypothermia, again, the skin's going to become really dry. A lot of times that person may feel quite weak and even dizzy. And a lot of times they'll have a rapid pulse as well. Now with hypothermia, it's the opposite. This person's usually abnormally too low. So I believe it's either at 94 or 95 degrees Fahrenheit, they consider that to be in hypothermic stage. And usually, again, this is due to a very long exposure to cold, or it can even be due to illness as well. When we think about hypothermia, again, one of the biggest issues is with burn victims or with drowning victims. Being in colder water that's not body temperature, hypothermia is something that you have to keep in mind, as well as those that have been burned and very severely burned. We have to keep in mind hypothermia as well. So when we start talking about this again with hypothermia, because they're trying to, the patient's basically trying to gain back that heat, you'll notice that they start to shiver. And a lot of times they'll see a little bit more of confusion, some loss of reflexes, and unfortunately that person can actually go unconscious as well. And hypothermia is very dangerous. Hyperthermia is very dangerous as well, but hypothermia is extremely dangerous because this can actually lead to organ failure and even death. All right, so some things to keep in mind too is that we do have elevated body temperatures that are going to take place. Again, we sometimes are going to have high heats that just overwhelm the body. And so again, this can happen if you are just really hot temperatures. If you're in Arizona or in Tennessee, you may hear of someone going through heat stroke, and they can actually collapse. It can shut down their cardiovascular system, and it can be fatal. But another pathological idea, or another reason that body temperature can be elevated, is due to fever. So I like to make mention of this. This is more along the lines of pathophysiology, but I still like to make mention of it. When we think about fever, there's a set point that is actually elevated by your immune system. And this is going to happen because of your white blood cells. They use it to help us fight infection. When they notice that there are pathogens or antigens in the body that they don't want there, their idea is basically to kind of cook them off. So you have these white blood cells that actually release what are called pyrogens, and pyro means fire. These pyrogens that help you to increase your body temperature when there's a presence of bacteria or a virus. And so the hypothalamus actually increases its set point on purpose to try to combat and get rid of these bacteria and these viruses. And we kind of made mention of this before when I used the term denaturation. Back in chapter 4, we talked about the idea of enzymes and them denaturing. The hotter something becomes, the more they lose their shape. Well, this is what happens to bacteria and viruses. It renders them inactive, and it can actually potentially kill them if the temperature is high enough. So your hypothalamus is actually increasing this set point to truly fight these pathogens. And what will happen is you'll originally feel quite cold. So a person that has a fever usually is shivering and shaking, and they say that they're cold. And that's the body's response, because when you shiver, you generate heat. Therefore, your body temperature is going to rise, and it's going to elevate until it hits this certain set point. And then finally, when a fever breaks, when that person finally stops having this fever and their body temperature stops elevating, they will start to feel cool, and they'll start to notice that their blood vessels dilate and they stop shivering. And then they're actually truly quite hot and trying to cool down. With fever, again, it all is sort of depending on the person and their age. Sometimes fever is actually a good thing. So having a slight fever, again, means that your immune system is functioning properly. Too high, obviously, is very dangerous. And so we have to be very careful with that. But that really has to do with age of the patient or person that you're dealing with, and some other factors as well. All right, now, when we think about skin, again, it's very important that we keep this guy intact, but sometimes that doesn't always work out. So we can lead to wounds, and we have to be able to heal it. And one great way to respond to this is via inflammation. So just as a heads up, if you ever see something with the suffix or the ending itis, bursitis, phlebitis, anything that ends in itis, hepatitis, oditis, those are telling you that it's inflammation. So itis means inflammation. And inflammation is actually a normal response of the body when it's stressed or has injury. And the attempt with inflammation is to actually restrict the spread of infection. It's trying to basically wall it off and keep it to one confined area, so your immune system has time to truly defeat that pathogen or that infection and not have it spread to other areas. So when we think about inflammation, there's some cardinal signs. You get redness, you get swelling, there tends to be a lot of warmth associated there, and it can also be quite painful. And the reason is because you have blood vessels that are dilating to actually make the area more permeable and allow fluids to leak into those damaged areas. And so again, when you've ever hurt yourself before, if you've ever cut yourself with a paper cut, you'll start to notice that it gets red pretty quickly, starts to pulsate. Sometimes it even is really, really warm and it hurts. And those are some of the reasons that it happens. You have blood vessels that are dilating. So it's bringing blood and fluids to that area, so it becomes more red. You're also bringing fluids to leak to those damaged areas, so it tends to swell up. That's why we see edema or swelling. And again, because of this increase in blood flow, you tend to feel that warmth. But you also now are going to have pressure on sensory receptors that trigger it for that pain. So that's some of those reasons that we see those cardinal signs. Just want to make mention of that. I'm not going to ask you anything on your test this time around, but I will bring this up in future. So I kind of wanted to make mention of it now that you've heard about inflammation. All right, so thinking about cuts, you can have a shallow cut or a deep cut. If it's a shallow cut, it only affects the epidermis. And remember that the epidermis is avascular, so you don't tend to see blood. And it's also going to pretty much heal very quickly. With a deep cut, now you can be reaching down into that dermis layer, that hypodermis layer, and you're going to have blood. And when that blood forms, it actually forms what's called a clot. And so these are just the steps of how that actually is going to form a scar and actually generate scar tissue. I will not be testing you on it this time around, but we will talk about this in the future. All right, and this is just a picture to show you the idea of a blood clot and how that healing occurs. Now, I will be asking you about burns. And so when we talk about burns, there are different types of burns. And so you can have some that are just a first degree, meaning that it's very superficial. And this is usually going to have no scarring because it really only affects the epidermis. This is when you get that really sucky sunburn that hurts for a couple days, and it hurts to even have like a sweater on your back or a shirt, and it's terrible. And you have lots of redness, you have very high inflammation, and you're going to notice that there's a lot of heat to this area. But again, there will be no scarring that is going to go with this, and this isn't fatal. The deeper you go, the more severe these burns become, and the chances for infection and even for death are going to increase as we go. So then we hit what's called a second degree burn. And I tend to more go with the idea of like superficial or deep partial thickness or full thickness versus first, second, and third. They just tend to make a little bit more sense. When you get to second-degree burns, we call it a deep partial thickness burn. And this destroys the epidermis, but you also are now hitting that epidermis. So this is going to be where you'll see blistering occurring. You're going to maybe even see some blood vessels that now have ruptured because of this. And it has a little bit more delay in healing because now you've actually gone a little bit deeper. And so this can usually have a complete recovery with no scarring, but it does take quite a lot of time to help to regenerate that skin. And then finally, when we hit this full thickness burn, not only are you destroying the epidermis, but now you destroyed most of the dermis and accessory structures as well. And so this can be usually requiring a skin graft or skin substitutes where you actually have a donor for skin. This can be very dangerous. And again, the much thicker the burn is, or the more the area is that has been exposed to this full thickness burn, the chances of death actually increase. The chances for hypothermia, infection, volume regulation, all become more severe. And this can be very, very dangerous. And again, this usually will have scarring. The person needs a skin graft where they can actually use their own skin, or they can use a donor's skin and to try to help them along the way. But again, this is the most severe and very dangerous to think about. So when we talk about burn patients, we use the rule of nines. And again, we use this rule of nines to actually estimate fluid replacement because your skin's normally intact and now you don't have this intact skin. So you're going to lose water, you're going to lose electrolytes. And so that's something to keep in mind. You're also going to have areas that are now very prone to infection because now instead of having this intact skin, it's a great area for microbes to reside in, and it can be very dangerous. As well as you're also losing heat too. So this is where we think of hypothermia being a problem. And so what we do is we use the rule of nines. So if you're looking from the patient from the anterior view, you'll notice that the head and neck are about 4.5%. The anterior trunk is about 18. Genitals are only 1%. Anterior legs and thighs are going to be 9%. And the forearms and arms are going to take up about 4.5% on each side. And then when we look at the posterior aspect, again, we can see that 4.5% on the posterior side of the head. We see 4.5 for the extremities, for the upper extremities, and then 9 on each leg for that lower end. And what happens is when you total this up, it comes out to be 100%. So we would use this to, again, try to really estimate replacement of fluids. So if we notice that the person had a severe burn on their trunk at 18%, again, that allows us to estimate that plan of how much do we need to give this person to try to compensate for those electrolytes that they're losing. Another big thing to keep in mind too with burn victims is that they are now having a much higher caloric intake. They need to eat a lot. And it's not because they're necessarily hungry. It's because of the fact that they need to maintain their metabolism. And most of your caloric intake goes to generating heat. Again, if you have an intact skin, you're losing heat. So you tend to eat a lot more, and you need to eat a lot more to deal with that replacement of fluids as well as for heat. So just something to keep in mind. And again, because now you don't have this perfect intact skin, you got a great area for infection to reside. So this is why we use the rule of nines to not only actually make plans for fluid replacement, but to also think about the chances for survival as well. So someone that has 60% burns is very severe and very critical. Someone that has 4%, maybe not so much. But again, we have to think about this when you have the patient that has been severely burned from head to toe, or has been in a house fire, or had hot soup, fall on them, or maybe fall on their chest. We have to think about those chances for fluid replacement as well as their probability of survival. All right, that is all I have for you for today. I hope you have a wonderful week, and I hope that everything is going well in your lives. I hope to hear from you guys soon. Thanks a lot. Bye.